All right, today we're going to tackle a really unique and honestly pretty misunderstood topic, neuroendocrine tumors, or NETs for short. To really get what these are all about, we have to start with a kind of mind-bending question.
So let's just start here. What if a tumor didn't just, grow? What if it could also act like a rogue hormone factory, just pumping out chemicals that can mess with your entire body? That one idea, right there, is the key to understanding everything we're about to talk about.
So what in the world are these tumors? Well, their origin story starts with some very, very special cells that have this kind of cool dual identity.
NETs actually come from something called neural crest cells. Just think of these as master cells that have a foot in two different worlds, one in the nervous system and the other in the endocrine or hormone system. It's this hybrid origin that makes these tumors so complex and, well, so interesting.
And because of where these cells come from, the tumors can show up in a few different places, but man, do they have a favorite spot. A whopping 90% of them develop somewhere in the GI tract. We're talking the appendix, the ileum, the rectum. Then you've got about 7% in the pancreas, and the last few percent pop up in the lungs or other places.
But here's where it gets even more fascinating. Not all NETs are created equal. They basically have two completely different personalities.
So on one side, you have what we call inert NETs. These are the silent ones. They don't make extra hormones, so you might not even know they're there until they get big enough to physically cause a problem, like pain or a blockage. But on the other side, you have the active NETs. And these are those hormone factories we were talking about, causing all sorts of symptoms directly tied to whatever hormone they're cranking out.
So let's zoom in on those active tumors, because the specific hormones they decide to pump out create these really distinct patterns of symptoms, what doctors call clinical syndromes.
A perfect example is something called a gastrinoma. The name tells you exactly what it does. It produces way too much of a hormone called gastrin. All that gastrin tells the stomach to produce a ton of acid, and that, in turn, can cause some really nasty peptic ulcers and pain. See, the name of the tumor practically tells you its game plan.
This is basically a lineup of the usual suspects. It's a fantastic way to see that direct cause and effect. An insulinoma makes too much insulin, and bam, you get low blood sugar. A glucagonoma makes too much glucagon, leading to high blood sugar and a really specific rash. A viphoma, it secretes a peptide that leads to severe watery diarrhea. Each one has its own unique hormone-driven signature.
Okay, so with all these different ways they can show up, from being totally silent to causing all this hormonal chaos, how on earth do doctors actually track one of these things down? Well, it's a bit like a medical detective story.
The whole process is actually pretty logical. It all starts with the clues, analyzing the patient's symptoms. From there, you move on to advanced imaging to find out exactly where the tumor is hiding. And the final step, the smoking gun, is a biopsy. That's where they take a tiny piece of the tumor to confirm what it is and figure out how aggressive it might be. And the tools they use for imaging are just incredible. You've got your standard MRIs and CT scans, but the real game changer is a special scan called somatostatin receptor imaging. Think of it like this. A lot of these NET cells have a special kind of lock on their surface. This scan uses a radioactive key that's designed to fit perfectly into that lock. When it does, the tumor cells light up like a Christmas tree, letting doctors see exactly where they are, anywhere in the body. It's amazing stuff.
All right, so the NET has been found, it's been staged. The big question is, what's next? What's the game plan for treatment, and what does the future look like? For pretty much all of these tumors, whether they're the quiet ones or the loud ones, the number one goal is simple. If you can, you cut it out. Surgery to completely remove the tumor is the most direct way to a cure.
But, surgery isn't always an option, or maybe the cancer has already spread. The good news is there's a whole toolbox of other treatments. There are anti-hormone therapies that can shut down the effects of those active tumors, and for more advanced cases, you've got targeted drugs and specific chemo cocktails that can really slow things down.
Now, I really want you to focus on this number for a second, because this right here, this is probably the most important thing to understand about the prognosis for a lot of people with these tumors.
Here's the thing, because many NETs grow so slowly, having a survival of 10 to 15 years is not at all unusual. And get this, that's often true even if the cancer has already spread. That's a completely different reality from many other cancers, and it's an incredibly powerful and hopeful part of this whole story.
And really, that hopeful outlook is the perfect place to end. We've figured out so much about these strange little hormone factories.
As science keeps digging deeper and mapping out their secrets, it just leaves you wondering, right? How much more effective and targeted can our treatments get? What's just around the corner?